right?
Yes.
Okay, perfectly. All right, very well, very well. Okay. Okay, if you see the presentation, we can start. The transmission. What do you say? Yeah, it's okay for you. Yeah.
Yes, sir.
All right. Okay. Okay. I am going to the presentation now. Well, I want to say hello, everybody. Hello, all of you. I know you are students of the University of Islamabad, the capital of Pakistan. Yeah, all right. And I listened a little bit about the voice of you, but if you listen well to me, that will be okay. All right. Okay. Right. The presentation of today is regarding some particular topical who is the posturological and posturometric diagnosis. That's very important topic, I think, for the people who are who are doing rehabilitation. Hello. Okay. Do you listen well, me? Yeah. Can you see the presentation and you listen well? Yeah. Yes. All right. Okay. I think you see in the presentation. All right. Okay. This webinar. I am Professor Di Rocca. I am the director of the NPR International School, as you know very well, and I am teaching all around the world with my school. And today is the time for second time in Pakistani University, and this is the second time we are there with all the students. Um, the topic of today, the webinar of today, I think, is a very important webinar for
Recording
the
in
whole,
progress.
the whole um, people who are doing rehabilitation, but also for all medical sciences. NPR is myofunctional postural rehabilitation. We did a webinar with all of you to present our protocol. Our protocol is myofunctional postural rehabilitation for all medical sciences, medicals, doctors, dentists, physiotherapists, osteopaths, every medical science can apply this kind of rehabilitation. Today we concentrate obviously in some topic who is the uh, clinical diagnosis and posturometric diagnosis. It is important, obviously, diagnose, very important. I think it's most important than technique. It's very, very important to make a diagnosis. With a good diagnosis, you can make a plan of treatment, and obviously, after that, we have to treat. You know, uh, the but why? Why we are saying that? Diagnose is a question. We are investigating what our patient they have. But I think the most important thing when we did the diagnosis is when we have to act. When we have to act. That's very important. The moment when we have to act. And then the treatment plan. But in the treatment plan, we say always we have to understand the priority. And for that priority, we will start our treatment. And how we do that? How we can do that? I think we have the tools to do that. Methods and tools. Method is the way where we are going to achieve our objective, and we have to use the right tools. Diagnostic plan is the main thing, and that's why the topic of the today lecture is diagnosis. In neuromuscular diseases, we do normally different diagnoses. Today we will point it in two of them. But in NPR diagnosis, we study the posture. And today we were talking about that. We study the craniofacial system. We will do some topics. How the craniofacial system affect the rest of the body. We're talking about that today. Oculomotor system. And we will see the diagnosis also. The foot support. Also, we do that in that webinar. And biochemical balance, we will not do this, not the topic for today. We concentrated in posturology and posturometric. And in the holistic diagnosis, we have to do a postural diagnosis, craniofacial diagnosis, biochemical diagnosis, foot support, physiological diagnosis, and instrumental diagnosis. And we will talk about that today. How to use a posturometer, who is an instrument, objective instrument that help us in our diagnosis. This is the two topics we will develop today. In the postural diagnosis, we study different things. In our school, we focus in the postural planes, and we will deal with that today. The thoracic brachial triangle, another good diagnosis. The rotation test, the convergent test, a differential test for the eyes, the march test that is nothing to do with the Fukuda. Is another thing you will see today. And we studied the foot support. We study for the first one. We study for the postural planes. Postural planes, I think, is a very important beginning. When we're talking about postural planes, we're talking about the bipupillary plane and the occlusal plane. These two planes we use in the craniofacial diagnosis. We don't use in posture. The main postural planes for diagnosis, they are the biclavicular plane and the biiliac plane. That's very important. You will see how we study the posture in two planes. When the muscle change, and you are physio, you work every single day with muscles. When muscle chains are in balance, equal balance, these planes should be parallel to each other. If something is wrong, they change and they advise to us some diagnosis. These postural planes, the biclavicular planes, is connected the clavicula, the external clavicula, the two parts of the clavicula. Obviously they are virtual planes. And some school call that planes upper buffer zone. We call that biclavicular in our school. The second plane is the biiliac plane and connect the right iliac crest with the left. When these two planes, when the muscle chains are in good function, these two planes are parallels between them. Eh, Posture is a good indicator of health of our body. That's why we focus a lot in posture diagnosis. These two, if muscle chains are equals, are in balance, they are parallels between them and parallel to the floor. But when muscle chains are not working well, we have hyperactivities in the muscle chain. How these postural planes will alter? The most common postural planes alterations are this. When we have an upper dysfunction and a lower dysfunction, these planes are divergent between them. They are like this. That's a good indicator. We can focus the next diagnosis in upper and lower alteration. That means craniofacial system, oculomotor system, or foot support. They are divergent, not parallel. Second alteration. If we have or upper or lower alteration, they will be parallels between them, but not parallel to the floor. Imagine, very simple diagnosis indicate us how to make a diagnosis. Carry on a diagnosis. This is the beginning. The characteristics is postural planes are divergent to the floor but parallel between them. That's the most common alteration as you see there. That's normal. This is two receptors altered, and this is one, upper or lower. And we have a beginning of diagnosis. So this is a test. We call that the rotation of the biclavicular plane. When the craniofacial system is disturbing the posture, the arms look different because we have inclination of the biclavicular plane. And if you put two cotton rolls in the mouth, and we repeat the test, if craniofacial system is altering, that situation change because we are relaxing the muscle chain. We see some patient. Look at this patient who have divergent planes. This patient have two alteration, one upper, one lower. But if you see there, how is the the situation of the hyperactivity here, that relation of muscle chain is because the jaw is not in the right position. Yeah? It's altering the muscle chain. And you see in front of is look also is look the arm shorter than the other. Here we have another patient. In this case, the plans are parallels. What they mean? We have or upper or lower alteration. Normally we take pictures of the front or the back also of our patient and the two lateral position of the body. Look at here. Another question. Imagine that. We will see forward that. Okay? The thoracic triangle, how it looks. Bigger than the other. And why we take the two profiles of our body? We taking the two profiles because when we compare the two profiles and they are different, we imagine we have three blocks. Look at this. This is different than the other, you see, and it's the same patient. That means that we have, in that kind of patient, three blocks: upper in cervicals, lumbars, and foot support. Imagine how the diagnosis can guide you to apply a treatment. Technique is good, but the most important thing is diagnosis. Look at that. Different postural alteration, different patients with the same exact problem. Postural alteration is very common all around the world, and it's very important to focus the diagnosis, to apply the treatment. An important thing is to apply an interdisciplinary treatment. We cannot treat alone any neuromuscular dysfunction. That's why we focus in an interdisciplinary action. Look at that patient. Look at here how he's bending. And look at the alteration, chronic alteration. Second diagnosis, the thoracic brachial triangle. Why we use that? These two triangles have to be equal, right and left. If they are different, as you see in this case, you see in this case, this one is bigger than this. They are not symmetricals. They are saying to us that that kind of patient have a short leg, and the short leg can be real or false. We have to identify later which kind of short leg we have. In that case, the short leg is this, is bending the biclavicular line and is bigger, this triangle. This guy is a real. In this kind is a real. But sometimes some biochemical problems can create rotation of the pelvis. And if the pelvis is rotating, it's a false short legs. Patient, look at see. And look at there. That is things that we have to investigate to make a diagnosis. The diagnosis have to be holistic diagnosis. We cannot do in a neuromuscular dysfunction, we cannot do just a local diagnosis. We have to integrate the diagnosis. Rotation test, and we add rotation and flexion. What indicate this test? This test is performing like this. You put on the back of the patient, you fix the trapezius and say the patient to move right and left. And when you feel a little tension, you stop it. And you can see if the rotation is limited or not. What indicate that? Indicate hyperactivity in the lower part of the muscles of the cervical change between third and 7 cervicals, hyperactivity. When we have hyperactivity, we have limitation in the rotation. And imagine, do you know that is related with the jaw position? Lateral deviation of the jaw is creating hyperactivity in the lower part of the cervicals and is limiting the movement. Imagine the interconnection. That's the form to evaluate, and that's the patient. What we do that. Flexion up and down. What indicated that test indicate hyperactivity of the upper muscles of the cervical chain in the first and second vertebrae. When we have limitation in this movement, we have hyperactivity suboccipitals area. Do you know that is related with normally with the retroposition of the jaw? When the jaw is in its back, is creating hyperactivity here, and that test is under limitation. Imagine how can treat it, how you can do physiotherapy or osteopathy or any rehabilitation if this system is disturbing. You cannot do that. That's why it's important to have a interdisciplinary diagnosis. Look at here, limitation, and look at here, limitation. And here, chronic limitation. Another test, the convergence test. That's very important test. Why? Because the eyes is one of the main receptors of the tonic postural system. We do the test, we perform the test by placing an element at the end of the nose, no more than 10 centimeters from from that area. We move slowly, 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 and say the patient, look the point. A normal oculomotor system who is working well can fix the situation for 15 seconds. If they lose the position after 15 seconds, we are saying we have in front the hypoconvergence. And why is important convergence? We will say why I have to test the convergence. When the convergence is not working well, we lose peripheral vision and we adapt the head. Imagine hypoconvergence can affect the neck and you want to treat here only. Imagine. Also, the jaw is affecting the neck. The eyes is affecting the neck, and the jaw is affecting the eyes. You will see later how we can treat that only with techniques. Yes, techniques is very important, no? But if you don't eliminate that situation, the therapies will relapse. That's the thing we have to think about. And that's the situation. Here we have hypoconvergence, and here the eyes is going external also. That is hyperactivity of the external rate. And that is another treatment we have to apply. And look at that. That is a research I did many, 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 many years ago, related the jaw position with the movement of the eyes. Lateral deviations creating unilateral hypoconvergence. Forward and retroposition is creating bilateral hypoconvergence. And imagine, jaw position also alter the neck. And that we see some patient with hypoconvergence. Another one, you see, bilateral hypoconvergence. But this hypoconvergence can be related with the muscle function. If we have a muscle who is not working, or we have a problem in the nucleus of the central nervous system, that can create also hypoconvergence. The differential test is to check if we don't have any central problem or any muscle problem here. How we perform that? We close one eyes, the eyes who was not working. As you know, we did some. I think we did with you the last time something about neurophysiology. I repeat a little bit. The movement of the eyes is co- the connection between those two eyes is with an special nucleus who is called Perlia nucleo. But Perlia nucleo is working in bilateral vision. If we close one eye, we annulate that nucleo. And if the eyes who was not making the convergence will do it when we close one eye. So we see differential test. That indicate that the problem is relating with the coordination of the both nucleus, oculomotor system nucleus, and we can say that that is relating, I don't say 100%, but 95% with the jaw position. It's a dysfunction. And you see that? That is the form where you do that. That is the convergent test. No? And then if we say to the patient that she close one eyes, the eyes move. That is the differential test. And the other one, close it, right. That is peripheral problem unrelated, sure, with the jaw position. Hypoconvergence. And if we do the differential test, you see the eyes can move. That is the differential test we apply. March test, another diagnosis, all right? The March test, it is not a Fukuda test. We do only 15 steps moving the legs. And why we do that? We are testing here the activity of the muscle change, the activity of the lateral right, lateral left, and posterior muscles. When we perform that, we perform in two ways. One of the tests is with the teeth no touching, and we repeat the test with the teeth touching. And we observe what happens. We say to the patient 15 steps, no more than that. And we observe what happens. And then with the mouth closed. And if you see when the patient closes the mouth, it's more instability. The patient is moving, you see. That means that craniofacial system is affecting muscles. How, how is working that? If we have hyperactivity on the right, the patient move left. If we have hyperactivity on the left, the patient will move right. And if we have hyperactivity on the back muscle change, the patient will move forward. Another test to see muscle change. And then we study the foot support. We study in two ways. We study the foot support in static two together, and then monopodalic. You see, and we study on the back and on forward. And we have to study the both. We study static. Look at here. This situation is because it's collapsing the metatarsal arch. We study how is the situation, if it's valgus or varus on the front. We study if it's, in that case, it's valgus one and varus the other. We study on the back if they are valgus or varus. And then we do the monopodalic also, the monopodalic test. You see here, the test, how it is performed. We say the patient to move one foot only. We see the patient to move the other one. And we study on the back. Like this. And we study on the back like this. With this test, we study the support of the foot, and we study if the foot is varus, normal, valgus, or disharmonic. With this diagnosis, we can see if the foot is adaptative or causative. Mainly of the fits are adaptative. Short quantity are causative. And we don't have to use insult immediately. We can do another treatment if it's adaptative. This is diagnosis to see if it's adaptative or causative. And foot most disaster is the disharmonic foot. We study the shoes. Obviously, have to be shoes that the patient use for a long time. We study this part of the shoes because with the walking, they adapt the shoes. And normally we think that situation is bad. That's not bad situation. This is not bad situation at all. All shoes are more consummated here. That's normal, not abnormal. Conclusion of the third part. Never treat just one part of the disease. Deal with a global interdisciplinary mind and treat the patient, not the disease. Open dialogue to heal. Study, analyze, and treat. Respect always biological times and respect the biotypes. You see a patient quickly. Look at that. This is a patient with a real short leg. I go for quick. Look at here how it's bending here. This is a short leg real. Triangle bigger here. Look at here the two different parts. Look how the patient is bending here. Look at here the convergence of these patients. Bilateral hypoconvergence. This is the dominant eyes, is the way what we see what is the eyes dominant because it's different the treatment. If the eyes affected is dominant or not. Here we see the patient, the test, the differential test, and here the other one. The extension test, foot support, how we study, one, the other, and on the back. One, and the other. Okay. The rotation, flexion, and march test. With the mouse open, and then with the mouse closed. Two different tests. The mouse, eh, forward position of the mouse with a little lateral deviation. Here, it's not good. And you see how the force that he is doing to open the mouse. Okay, bruxisms related with the jaw position. One time we can do some lecture about bruxisms. It's very important to understand. We have a mixed understanding in bruxisms. Okay, from the back we can see here the lateral deviation of the patient, and then we see shortly how the craniofacial system affect the system. Hey, we're going to see how the craniofacial system alter the muscle change. The muscle change is muscle reaction. It's a reaction through the muscles. And when the craniofacial system is disturbing, it's affecting that. Okay, we have here the balance is mind body biochemistry. We know that very well. And that's very old. This professor, Musi, was an Italian professor. And we studied that in 1936, the jaw position and postural alteration. Forward position and postural alteration. Very, very old. We leave it for a long time. But we have to, coming back to that diagnosis. NPR is a myofunctional postural rehabilitation who is dealing with the posture. You know if craniofacial system is working well. We have a good posture. You saw that before. And then if some is altered, we can alter the situation. Look at that, the jaw position, lateral deviation affect the muscle change in a lateral way. Forward position affect the muscle change forward and back. And look at that, that's very important. These things I told you before, how the jaw position is affecting suboccipitals, how it's affecting this area and this other area. This is the muscle that craniofacial system affect. The hyoid system is important connection between upper part of the body and lower part of the body. The hyoids connect, and when the lateral deviation of the jaw is present, we have an alteration of the biclavicular line, the postural plane we saw before. We will talking later about this. Posturometric and how lateral deviation is affecting. Look at here. Mouse open 4 kilos of overload. Patient close the mouse is increasing to 9 kilos. That is a proof that jaw position affect muscle change. This is an objective diagnosis. And we see a short video regarding the hyoids. The hyoids is a very important bone, but it's connected with muscles. The muscles are connecting hyoids, jaw, and last the neck. Any jaw position is altering the neck. The hyoids, when the jaw position is not good, it's starting bruxisms, and the bruxisms create hyperactivity and it's blocking the craniosacral breathing and then the posture. That's very important to understand. Very, very important. Temporal. Here is the temporomandibular joint. We have to understand we have a lot of vessels, a lot of irrigation, a lot of nerves in this area. If we create hyperactivity, we create a lot of problem in this muscle area. And that's, I told you before, the retroposition of the jaw. This position is creating hyperactivity there, but not also there. Here, here, and here. And slowly, slowly, this situation is creating the hyperactivity of these muscles and slowly, slowly is going down. It's blocking the cervical first, but slowly it's going down, going affecting the trapezius, it's affecting the muscles here, big muscles. This is affecting that joint. And slowly going down is affecting and arriving to affect also the foot support. That's important to understand that. Very important. All right. Scoliosis. Mainly of the scoliosis are functional scoliosis related with all of these situations we are talking today. Scoliosis is rehabilitation topic. It's not mechanical correction. It's rehabilitation. Mainly of these scoliosis are dysfunctional scoliosis related with foot support, mouse, craniofacial system is doing scoliosis. If you treat all and you do a good physical rehabilitation, scoliosis disappear. And look at that, mouse and posture. That patient with a lot of symptomatology, headache, neck pain, diffuse muscle pain, dizziness, bilateral clicking, all these things creating a postural alteration. Look at here, the oculomotor system, and if you see there, the craniofacial system disturbed. And how is altering the posture? How is altering the posture? eh, If you see that situation, altering the body center, etc., etc. So that's important mission. And then we're talking shortly about posturometer, posturometry. Posturometry is a science who measure the posture. The other things we did is a clinical diagnosis. Now you will see how we can do a instrumental diagnosis. Instrumental diagnosis with the posturometer. Posturometer is an instrument, an objective instrument designed special to measure the posture, but it's not the instrument, it's the protocol of diagnosis we apply to read the measuring. Someone in Italy, Galileo, said, eppur si muove, say, it is moving the hairs. He cannot demonstrate that. That's why I say, okay, if he's not, they kill him. They say, all right. You are right, but the hairs is moving. Okay, if he can demonstrate that, the situation will be different. Okay, posturometer can demonstrate the alteration of the posture. We can prove it. We transform our diagnosis, mission. We transform the clinical diagnosis in science. What is posturometry? Posturometry is a diagnostic test used, not invasive, to measure the different postural alteration that we saw before in the clinical test. Measuring posture allows us to monitor our treatment's progression also, and that's very important. If you measure, you can see if your technique is going well, and if it's not, you can change the way. It allows us to access postural receptor function. What means we can test if postural receptors are working well. If it's not, we can treat them. Measuring posture, we can evaluate if the main receptors are in balance between them and with the postural tonic system. That patient, look at that. Mouse, eyes, posture. That patient, short leg, mouse, eyes, posture. How we treat it? Alone? We cannot. But if we measure, we can guide our treatment. Posturometer is a real good instrument, objective instrument to measure the posture. eh. Many years ago, that was one of my professors. In 1992, I went to Seattle to study with him. He said, clinical opinion may be true or false, but is only an opinion. When we can measure it, it is transformed into science. Dr. Bernard Jenkinson, very nice professor to me. eh? And that's why we said if we measure posture, we are transforming clinical opinion in science. Posturometer, a new way for diagnosis and therapeutic treatment in NPR. Posturometry is the science that study and measure the static posture of the body, measure the static postural balance and relate this the activity of the postural receivers, eyes, mouth, and foot, to see if they are in balance between. If it's not, we can study what alteration they are creating. What does this guy in common? If I ask to you, and the answer will be a lot of answer. Maybe you say this ronde posture is, oh yes, the biclavicular plane is muscle alteration. No, the common, this have in common is the search of the best center of gravity. The best center of gravity. Always. Our body is founding the best center of gravity and is making adaptation of the body to found it. The central nervous system seeks at all times the very center of our body to see if it is closest to the center of gravity of the earth. Why? Because in that position is using less energy. To found the very center is making adaptation. That's why I say scoliosis is an adaptation, it's not a disease. Posturometry. The objective of the central nervous system maintain the center of gravity, conserving energy. Don't forget it. Constant balance in all situations. How did change the center of gravity? Zero. But to have that center of gravity is making adaptation to the shoot. All of them have problem in the lumbars. And what about the shooter? He maintain the center of gravity to have a good shoot, but make adaptation. Maximum energy and less resources, afferential and efferential, and less use of muscular apparatus. What happens when the central nervous system is facing the aggression? That means pain, escape, escape of the pain. If I have pain on the right, I escape to the left. If I have pain on the left, I escape to the right. And we can measure that with the posturometer. Reacts automatically central nervous system to find this ideal center of gravity in relation to the efficiency and of afferences and efferences. The information will come up and exit. Look at this in a chair. A single voice who is not in tone, the whole symphony is a disaster. The same in the tonic postural system. If one receptor is working bad, the whole system is working bad, but it's working. We cannot stop. We work, but ideal center of gravity to have balance. All part of the body form a circle, as you see there. All can be the beginning of the end. Anywhere we start to observe the circle, we will find reflection of a pathology located elsewhere, and we have to measure that. Some problem here can create problem in the foot. Some problem in the foot can create problem in the mouth. Some problem in the biochemistry can create problem in the muscles. Posturometer and the structure of the posturometer and stabilometer platform, which we are talking now, is based in the Kappanji body weight distribution. You know very well Kappanji as a physician. He studied that distributed in the first metatarsal, fifth metatarsal, and calcaneus. The posturometer have three sensors, and this we know that the distribution is 36% in the calcaneus, 26% in the first metatarsus, 16% in the fifth. The triangle. The bisectrix of the triangle is the body center where they meet. This is the body center of the feet. We have to positionate the foot. This is a line. We position it here, the calcaneus, and in between this line, the first and second metatarsus, and then we can repeat the register anytime as you want. And that's the science. This is the posturometer. The purpose is to test oculomotor system, craniofacial system, and podalic support. We put the patient there in front of a wall, no more than 80 centimeters, and then three tests: open mouth, eyes open; closed mouth, eyes open; open mouth, closed eyes. Three different tests without the patient coming out. And then in these three tests, we are doing posture. We study posture, occlusion, and foot support effect into the muscle change. Okay? The craniofacial system, we know very well, is altering that. Sometimes it's altering, sometimes it's a victim of the posture. Look at here. 0 kilos. The red colors here, the red colors. This is very difficult in a short lecture to explain the posturometer, but I try to be synthetically. Okay. The red color is alteration. The green color is normal. Okay. And then here, the colors, the overweight, we can have the overweight to the, in this case, of the right. We can study with the protocol. The triangles, we can study as a traffic light. Red is alteration, precaution, and then is normal. The craniofacial system can sometimes, because of the problem, sometimes can be victim of the problem. Look at here. In this case, without dental contact, the posture is 5 kilos to the left with the mouth open. The patient's close his mouth and look at he's trying to do better the posture. In that case, the craniofacial system is victim of the situation. Look at this. With the mouth open, the patient have 5.5 kilos to the left. And when the patient is closing his mouth, look at here, the posture is increasing to 7. In that case, we have the problem of the posture is created by the mouse. This is alteration. We can observe the barycenter. The barycenter, we can observe the center of gravity. Look at here, the center of gravity is back. We can observe this detail. It's very difficult to explain in a short lecture what they mean, but we can observe the comfort of the patient, the hyperactivity of the muscles, and we can observe the relationship of the form, the vision, the convergence. We can measure everything here. We can even measure the center of gravity, how it is. In this case, is to the right and back, and we can observe the comfort with this value. We can observe the vision. It's very difficult in 1 hour lecture to explain posturometric diagnosis, but just to show we can use different graphics. We can, with this is important for you. The area who cover, we can study the hyperactivity or hypoactivity of the muscle. If your work is working well or not, if it's creating or not. Clinical cases. I want to show you some clinical cases. Okay. Short leg, real short leg, mouse problem with the lateral deviation to the right, 5 kilos here, 4 kilos. That's the victim. A real short leg is creating problem to the jaw. Look at here, the second patient I showed you before. 5 kilos, 7 kilos. Here, patient is causing the craniofacial system, is causing the problem to the posture. Right? In the beginning, another patient. The beginning, look at here, losing weight in the calcaneus, moving forward, losing pressure there, moving forward, and creating overload in this area. After treatment, the treatment was a bed device. Sometimes we will do some lecture, if you like, about the device for physios to annulate the craniofacial system. Look at here. With the bed device, we correct the insole to the patient to correct the short leg, and they annulated the craniofacial system. Zero overload. The body center is balanced, the center of gravity is okay, and the whole body distribution is perfect. Just study first, annulating the short leg and annulating the mouse. And then the physical rehabilitation is going well. Before and after. Follow us in our media. You have, if you want, this is our media. The lecture is finished today. This is our school. This is our application. If you like, you can follow us in our channel, in all our social media, Telegram, etc., 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 Twitter also. I hope in this short time I be clear to these topics. I hope you. I hope I see you in the future in your in your in your faculty in your school, and then I will stop to interrupt the the sharing, and if you like, we can do some questions if you want to me. If you want to make some question to me, I am here. All right. And if it's not, we close the lecture today. Yeah, I see a lot of students there. All right. Yeah. If you have any question, I am here. If it's not questions, I will see you in the next time in your faculty. Okay. If you have any question, I am here. You can ask me. If you are tired, you can go home. All right. Okay. I can listen very well because it's some difficulties in your voice. If you can write the question, if someone to can write the question in the chat, it's very difficult the sound. I cannot hear very well you. A little bit. It's a difficult the voice. Okay, let me close the transmission in my YouTube channel. I have to say hello, bye bye. And my colleague is in YouTube channel, and then I will go with you in a minute. Okay, okay, bye bye YouTube. Do you follow me in YouTube? And see you in the next transmission.